And that may involve medications if it's moderate to severe, but otherwise therapy and behavioral activation and social engagement are key. We are all human. We need to connect with one another. We need to get outside. We need to feel love and be able to love. And so it's all about that holistic approach, guys. Hello and a warm welcome to another mental health Q&A. I had a lot of fun doing this one. We talked about feeling emotions as an adult, which is harder than it seems. We talked about depression. Is it nature or nurture or both? We talked about why is psychosis actually bad? We talked about OCD and schizo-obsessive presentations and schizoaffective disorder. And we talked about bipolar 2 and hypomania. If you're new here, my name is Syl. I'm a junior doctor from Australia. I work in the mental health field. I'm training to become a psychiatrist, and I make these educational videos in my free time. And if you enjoy these kinds of videos, please consider leaving it a like and subscribing to the channel. But other than that, let's get into it. All right, first comment, and this is an excellent comment by KME. I have a question. I'm bad at tolerating emotions and wish to get better at sitting with hard emotions, but I do not know how. I've heard just sit with it and ride it as a wave, but I find that it's not that easy. How do you learn to tolerate emotions? Oof, that's a big one. Look, I think the first place to start with this question is to ask how a child learns to tolerate emotions. Like, what is the natural path to learning how to develop emotions? And then kind of think about how then adults can learn in a kind of secondary phase. So if you haven't had ideal early life experiences, or you know your genetics are such that your temperament gets much stronger emotions than other people, and tolerating emotions is extremely difficult, then essentially you need some strategies to learn how to do it as an adult. But when a kid learns how to understand emotions, it's really modeling of the caregiver. And a kid's nervous system is completely out of whack. It is completely disorganized emotionally, and it is actually the caregiver who organizes the kid's internal world. So a kid's ice cream falls off the cone onto the floor, and it's the end of the world. It's the worst possible experience the kid could imagine, and they are so distressed. And then the role of the caregiver is to organize that and say, oh, look, I can see you're feeling really sad, but it's actually not the end of the world. We can get another one, or, hopefully the kid gets another one, because that would suck if you don't get another ice cream. But then the kid is cuddled, and as the emotions settle, the kid is learning the appropriate emotional response, which is what the caregiver is displaying, that it's sad, that it's a shame that they lost their ice cream, but that it's going to be okay, that they can trust the world and they can trust their caregiver, and that the emotions they're feeling will settle and are manageable. So it's really in the attunement with a caregiver that the intensity and the the intensity and the quality of emotions are understood and felt. But for all kids, there's a period where emotions are completely intolerable, completely out of whack, and that's a normal developmental phase. And so, terrible twos and 3-year-olds, their emotions are completely disorganized, and if you had to diagnose them, you would say they have severe emotional dysregulation, but it's obviously a normal developmental phase, because they're learning via the attunement with the caregiver how to feel. And you can see it in their heart rates and things like it when even in a newborn, when you look at a preterm birth of a neonate, like a baby that's born too early, and they're stressed, right? It's a very stressful thing to be born, and if you're born early, your kind of unconscious nervous system is completely premature, and the heart rates can go through the roof. But when one touches and soothes, then at the even more primal level than emotions, at the biological level, the heart rate will settle. There's something about touch and connection that calms our nervous system. And so it's interesting to think about how attuning to caregivers settles our unconscious autonomic nervous system, and then how, with so many people who have mental health and emotional dysregulation struggles, they also tend to have problems in their autonomic nervous system. So things like POTS, where the changing position results in your heart rate changing rapidly, and other sorts of issues as well. So something to think about there. So that's how a child kind of learns emotions. So, for whatever reason, if you're an adult and emotions are hard to experience and tolerate, and so the way you manage that is, I don't know, there's different ways to manage it, either avoidance or acting out, explosion, getting angry. Then really it's hard to kind of by yourself learn how to tolerate emotions. It kind of needs that relational element, and that's what therapy is there for, right? That's the role of therapy. Now, if you don't want to do it, that's fine, but what I'm hearing in this comment is that you want to learn how to tolerate emotions, and you heard the kind of tip to write it as a wave, and there's all these kind of CBT techniques you can use to handle distress, and DBT as well. So these are two common types of therapy, so cognitive behavioral therapy and dialectical behavioral therapy, and writing it as a wave is a kind of more DBT technique actually, and it's all good, do that, but I guess what I'm thinking about me as well. So I was a pretty, I always, I wasn't, so I always display a lot of positive emotions because I was this kind of happy-go-lucky, naturally positive temperament kind of guy. But I remember I went to a play and with my best friend, and it was Les Miserables, and there was just this beautiful scene, a sad scene actually. So it was beautiful and very sad, and I was kind of I was 19 or 20 or something, and kind of little macho maybe, and didn't want to display sad emotions with my friend. And then I looked over and he was just crying, and that to me modeled, I remember it now, how interesting, that to me modeled that it's okay to cry, in front of your friends. And I hadn't had that experience before then, interestingly, or for whatever reason that was really profound. But my point is that he modeled what I am allowed to do, so I had to see it in someone else. And similarly with when you do therapy, your therapist models how to feel emotion, what emotion is, and notices it in you. So you might say, I'm really, really angry, and then the therapist might be like, okay, I can see there's a lot of anger there. I'm just wondering what's underneath the anger. It's like, it sounds like it's a bit of shame that you're trying to avoid, or and those kind of insights, when you start to learn your own emotional landscape, helps you have a more authentic and deeper life. It's as simple as that. So my like one, if I had to summarize my advice here, it's that you learn to tolerate emotions through healthy relationships, and if you don't have a relationship like that, then therapy is really important. And really, I think if you're struggling with displaying emotions in your adult life, then therapy is a really good place to learn how to do that. And if you go into therapy with that goal, I'm sure the therapist would be, would love that goal. Different people go into therapy with different goals, so it's good to think about what you want to get out of therapy, and this is an excellent goal for therapy. All right, sorry for that long answer, but I thought that was a really good question. The next question is by Stony Val 1239. The second question leads me to another question of what exactly is psychosis and why is it so harmful? If the anxieties and everything affecting the quality of life can be explained in other ways, couldn't the psychosis be explained in those ways as well? Just because people believe something doesn't mean it's wrong, right? How else would you explain trauma responses? And if dealing with somebody with, say, borderline personality disorder can literally drive you crazy and put you in psychosis, wouldn't that be better explained by trauma and not some kind of brain dysfunction? Lots of different questions in this awesome comment. So thanks for the comment, Stoney. Really good comment. Okay, first thing, what is psychosis? Psychosis is impaired reality testing to the point where it causes functional decline, right? So we all have some ability to see what's real around us, what's not, what's in our own mind, the separation between the external reality and the internal reality. To some degree, we all have that, but that degree changes, and within the same person can change through the day. Under stress, it can change, and if you have a mental illness, that ability to know what is you and not you is very different, is changeable. So kind of understanding the boundaries of the self and not self, right? So, this cup is not me right now, right? I can see that. Someone with a deep paranoid psychosis might feel like that cup has something to do with them in a very deep way, like it's monitoring them, or it's emitting kind of radiation that's connecting to their brain and causing some kind of dysfunction, as an example. So that's what psychosis is. So why is it so harmful? Look, it's not always harmful, okay? There are plenty of people that live with low-grade psychosis, so to speak, and live out their lives and cause no issues, and I'd never know about it, you'd never know about it. It's no big deal. It's harmful when harm comes to them or others, or they're not living to their quality of life is not as good as it could be. So you only kind of intervene when there's significant impacts on quality of life to the self or the others. So, for example, if someone's feeling extremely paranoid, like they're getting stalked, and so they attack someone who they feel is, a bikie stalking them, that's a problem, right? You are a member of society, and you have a duty of care to be safe in that society. Okay, so that's when it gets harmful versus not harmful. The other thing to say is psychosis is, I guess, a broad term, and it's helpful to think about the different diagnoses. So there's chronic psychotic disorders like schizophrenia, and then there's brief psychotic episodes, which anyone can get, right? I could get that if I didn't sleep for a week, took lots of stimulant drugs, and then had significant social stresses, like my partner broke up with me and someone in my family died, I could definitely develop a psychosis, okay? So anyone can have a brief psychotic episode, and then sometimes you can just have perceptual disturbances. So your visual system is not 100% perfect. And in fact, the way you see the world is not just, you don't just look and take in the world as it is. That's not how eyes work. Actually, what happens is you walk into a room, your brain generates a model of the room and what you see, and then your eyes go around confirming the model. That's how vision works. And so your eyes are actually projecting. So if you're in an anxious state, then your eyes can incorrectly project into that model. So right now, when you're looking at this screen, there you have two blind spots that you're projecting kind of value into. So you're projecting the kind of pixels on the screen and the shapes, because your brain has the optic nerve coming out of the eyes, and there's no photons in that area. So you've just got two blind spots, but you don't see them at all because you're filling in the blanks. And in the same sense, your brain is filling in, the model of the room. And so if you're in a very anxious state, you might project, especially in the peripheral of vision, something that looks like a scary man or a ghost or something like that, and then you look and it's gone. And so actually that's not a psychosis, that's kind of a anxiously driven illusion. But anyway, I digress. Just to say that our ability to perceive the world is fundamentally flawed because of our biological limitations. So what's the next part of this question? So just because people believe something doesn't mean it's wrong, right? How else would you explain trauma responses? Look, I guess we're getting into truth and not truth, and philosophy and right and wrong. I guess all I would say is that trauma, the last part of the question is also like, can something be explained by trauma and not brain dysfunction? So trauma and the body are deeply interconnected, and the brain and the body are two sides of the same coin. Okay, so trauma affects the brain, affects the body. You can think of it like a triangle if you like. Read The Body Keeps the Score if you want to understand how the body and bodily memories link to trauma, and the idea that the brain is separate from psychosis or the body is defunct. It is absolutely the case that trauma affects the brain, and trauma can cause brief psychotic episodes, definitely. And I've seen it many times, and after 24, 48 hours of treatment, the psychosis is like completely resolved, and it's kind of shocking to see someone go from this, like, you're like, this is a pretty kind of impressively significant psychosis, and then within 24, 48 hours, it's gone, and they're back to baseline, and it's because of the level of dissociation, the level of stress, the level of reality testing was completely impaired due to the overwhelming stress, and they're getting perceptual abnormalities, and then with reduced stress, essentially protection of sleep, which is one of the most important treatments in that kind of state, then things get back to baseline, which is just excellent. Yeah. So I hope I answered that question. It's a tricky one, but perceptual disturbance is also very common in borderline personality disorder. And so a lot of people, it's really, like, it does happen that people with severe borderline personality disorder get a diagnosis of schizophrenia. And you just got to really think about the perceptual disturbances as to whether they're a psychosis or not. And it's very helpful to remember that psychosis is a syndrome, and it doesn't happen in isolation. So if someone has having auditory hallucinations with negative self-talk, but they have preserved reality testing, so they know that it's in their head, not in the room. It's not affecting their ability to work or have relationships. They have retained sociability, so they know that I exist. They know I have my own internal world. They know that I'm not. I don't know. They're able to understand that I'm a separate entity. And also the other thing is that it's often stress mediated. So if you have borderline personality disorder with auditory hallucinations, they tend to get worse when someone's under stress, and then better if things are going well, as opposed to typically what happens in psychosis, where they are not directly linked to emotional state. So there's all these different kind of ways to kind of disentangle what is a primary psychotic symptom or a secondary BPD symptom. And yeah, that's why you need to see a psychiatrist if you're worried, because we do the training to try and disentangle those. Very hard to disentangle though. But what you would want to kind of be cautious of is being on lifelong antipsychotics because of BPD-driven auditory hallucinations. Just to be clear, BPD, borderline personality disorder, not bipolar disorder. And so you just want to kind of have accurate diagnostic clarification. That's why you need to see a psychiatrist. Okay, next question. All right, are there any doubts about hypomania/bipolar 2 in psychiatry? Is it thought of as a real or mania bipolar 1 or bipolar 1 that hasn't fully developed yet? There are doubts as to whether it's a useful diagnosis. A lot of hypomania could be thought of as emotional dysregulation, and it can be very challenging to disentangle what is one or the other. And I guess it's an important thing to disentangle because a primary kind of mood disorder driven change in energy has a different treatment to an emotional dysregulation change in energy, which comes from maybe personality structure and emotional management issues, emotional dysregulation issues. Yeah, so there is ongoing debate. Personally, I don't make a bipolar 2 diagnosis often, and I've found I found the most helpful distinction factor is mania with or without psychosis. That's critical because that informs whether you should add an antipsychotic. But really, mania is like when you see mania and you see emotional dysregulation, they're very different things, and so it's risky to kind of. I actually find it kind of risky to have a bipolar 2 diagnosis because Sometimes you're on a bipolar spectrum, sometimes you're on a personality dysfunction section and spectrum, and they're two different treatments. So it kind of is a blurred area. So that's my experience with it. So there is ongoing debate in psychiatry circles. It is a legitimate diagnosis. So if that's how your psychiatrist has formulated you, then that's excellent. Good for you. And if it's working, if it's not working, then maybe you need to kind of try and disentangle whether it's more of a bipolar or more of a personality coping mechanism dysfunction kind of pattern. Okay, next question is, what are the differences between intrusive thoughts in obsessive compulsive disorder and those kind of thoughts in schizoaffective disorder? I've been told that my intrusive thoughts are due to the latter, but I wonder what the difference is. So, good question. In one of my previous videos, I talked about the difference between overvalued ideas, obsessions, and delusions. So OCD is having, just as a quick rundown for everyone watching, OCD, everyone's heard it used colloquially, but there's a couple things that are different compared to the casual use of the terms. So I'll just explain. An obsession is intrusive and ego dystonic. So it's inconsistent with the person's wish to have the thought. So it's painful. Okay, so if someone says, oh, I'm obsessed with this TV show, I love watching it, it's all I can do. That's ego syntonic. They like that thought, that it's not causing distress. They're happy to have that, interest. And if it's super intense, then that can be an overvalued idea. And if it's incredibly fixed and false, and if it's incredibly powerfully held and fixed and false in its nature, then that can be a delusion. Any belief, right? But an obsession is painful, right? And it's so painful that there's often a compulsion to fix the obsession. And a compulsion is the psychodynamic term is, it's a magical thinking. It's a hope that doing this physical root behavior will fix the pain of the obsession. So let's use an example. I have this obsessive thought to kill my child, right? Very painful thought. No parent wants that thought, but it's dominating my mind that if I'm holding my kid, I'll kill them, right? So what do I do to avoid that? Well, I'm going to tap 8 times. I got to tap 8 times. And as long as I'm tapping 8 times, I'm not killing my child. So I just got to keep tapping 8 times. Okay, I can't go to work because I got to keep tapping 8 times. If not, my child will die. So that's how OCD can kind of get out of hand. And it causes obviously a functional impact that's significant. Now, so that's obsessions and compulsions. Now let's talk about schizoaffective disorder. Schizoaffective disorder is a chronic psychotic illness like schizophrenia, but also has a mood disorder component. So you might have chronic psychosis, which might be hallucinations, delusions, passivity, which is when you feel someone else is controlling your body, paranoia, that sort of thing. And then there's also a mood disorder element. So maybe episodes of severe depression or severe mania or both. So it's kind of a pretty tricky diagnosis, right? It's kind of the worst of both worlds of mood and psychosis, and hard to treat. And if you have an OCD as well as that, it gets even more trickier. I guess once you have 3 diagnoses here, like schizoaffective and OCD diagnosis, what you've got to understand is these are 3 labels to explain one person. So you're not 3 things, you're one thing, you're one person, right? You have one experience, but we have different labels to explain your series of symptoms. So I just make that point because I think it's important. Now, your question is, what's the difference between the intrusive thoughts of OCD and thoughts of schizoaffective disorder? So in schizoaffective disorder, I guess an important point is there is a presentation called the schizoobsessive presentation, which is when someone has such severe obsessions, so ego dystonic, intrusive, painful thoughts, so severe that they cross into delusional intensity and can correlate with other psychotic symptoms. Now, that schizoobsessive picture is not a kind of clinically protected term. It's not in the DSM or in the International Classification of Diseases, but it's an interesting term because it is a kind of pattern that repeats that we see. So how do you know when a thought comes from one or the other? I mean, your psychiatrist is probably the best person to explain this, because I don't know what thought you're talking about. But I would just say that if it's a kind of a thought that's felt to be a delusion, which you might not agree with the psychiatrist that that's the nature of the thought, and you're entitled to getting a second opinion. But if you're experiencing a delusion, often you don't have insight with that, and it usually comes from other people saying, "Oh, look, I think that's not based in reality. That fixed and false and intense belief you're having is maybe not as real as you feel it is." Which it's a very difficult situation. I guess when it comes to delusions, I always try and think about how painful it would be for me to find out that I'm actually not a doctor. Like, someone comes to me and says, "Look, Syl, I know you're 100% sure that you're a doctor. I know you've got all these memories of you working as a doctor over the last 5 years, but it's a delusion. You're not actually a doctor." Like, I could not believe that, and I would think that person is mad. but that's that's what it must be like to find out, or to be challenged on a belief. So, always best done delicately, of course. But if your psychiatrist is saying you're having thoughts from a schizoaffective disorder, it could be from the psychosis part. It could also be from the affective part, which is mood. So if you're having really negative, depressed cognitions, like you're worthless, there's no future, your body is rotting, that kind of thing, that could be from the affective part of the disorder. All right, let's do one more. Running a bit over time, but that's fine. Thank you for staying for so long. The next one was a message on Facebook. So, settle a debate for me. My mum had depression, now I have it too. So it's a genetic disorder, right? No, but there's genetic components to it. It's all nature and nurture and epigenetics, right? So if you have a mother who suffered with postnatal depression, not talking about you, but you can imagine a situation where a depressed mum can't care for the child. The child then, in the first years of life, models the world as a scary, dangerous, not dependable place because they weren't attuned to, which predisposes to being depressed later in life. So that's not just a genetic thing; that's also an early environmental thing. It's why the first 1,000 days of someone's life is so important, from conception to 1 to 2 years old. So no, it's not just a genetic disorder, but it's a mix of genes and environment. But yeah, I guess my controversial take is that it's slightly. I just think it may be slightly more environmental than genetic. But anyway, that's just my own theory. I'm just thinking about it. It's very hard to prove these things. People say, "Oh, look at these twin studies," but if you're separating twins at birth, there's something else. There's going to be environmental impacts, and if you're comparing, twins in the same family, doesn't necessarily mean they have the same environment. So it can be a little tricky. But anyway, what everyone agrees to is that it's not a 100% genetic or 100% environmental thing. It's not even that helpful to think about. The fact is, if someone has depression at the moment, it's a multimodal, holistic approach to get them better, and that may involve medications if it's moderate to severe, but otherwise therapy and behavioral activation and social engagement are key. We are all human. We need to connect with one another. We need to get outside. We need to feel love and be able to love. And so it's all about that holistic approach, guys. All right. Hope that was a quick and dirty answer. But yeah, that's the best I can do with the short time we've got left. So guys, I'm going to leave it there. Thank you so much for all the comments. If you want to keep seeing these kinds of videos, all you got to do is keep commenting questions. I have noticed over the last week the amount of questions has gone down, so that's fine, but these videos will come out less often. But if you've got good questions, put them in below, and then I can make more of these videos. The other best way to support me is just leaving the video a like and subscribing to the channel, sharing it with a friend. But other than that, I'll just leave it there and wish you all a beautiful day. Okay? Bye for now.